righty, welcome back everybody. For those of you that are joining us for the first time today, welcome to Module 4. This is Latinos and Suicide, a Clinician's Guide to Suicide Prevention and Treatment. The content that is used within this PowerPoint presentation was developed by Dr. Luis Zayas, Dean Zayas, who has done a tremendous amount of research into Latinos and suicide, and even narrowing that down more specifically to the family dynamics and Latinas also in suicide, as they're dealing with those issues. Also, as we see this uptick right in our country on Latinas attempting and taking their life by suicide. So welcome back. I want to welcome those of you that are again attending for the first time today. Those of you that are coming back to us, I appreciate you joining us. Today we're looking at Module 4, Assessment, Prevention, and Intervention. I am Rocky Romero. I am a technical assistant, contractor, and also a trainer contracted with the Mental Health Technology and Transfer Center out of the Universidad Centro de Caribe School of Medicine in Bayamón, Puerto Rico. So thank you to them for supporting our work and this work that is very much needed in our communities. I want to, before we jump into this, just want to ask that we take a moment of silence for those that have taken their lives by suicide, given that we are in Suicide Prevention Month and last week. So moving that forward into the full month was our intent. So just a moment of silence, please. Alrighty, thank you so much. So today on the 27th, we will be together for about an hour and a half. Hopefully I can stop right around an hour and 10 minutes or so, hour and 15 minutes, and allow there to be any questions that may be presented or posted. I also want to let you guys know that I included 3 handouts that we're going to take a look at here at the end of our time together, which is the APA Cultural Formulation interview from the DSM-5. We're also going to look at the Columbia Scale for suicide, and also one website that I want to show you guys real quickly. Some of you may be familiar with it, but it's the website Zero Suicide, which is actually a national effort that's aimed at reducing and preventing suicide. As a reminder from our presentations last week and week before, the MHTPC network uses affirming, respectful, and recovery-oriented language in all of our activities. We intend to use language that's respectful, clear, and understandable, non-judgmental, while avoiding assumptions, a person-first and free of labels approach that is inclusive and accepting of diverse cultures, genders, perspectives, and experiences. And we always hope, of course, to come from a healing-centered perspective that is responsive to trauma that Latinos are experiencing at significant rates in our country. With that said, we always want to make sure that we're consistent with our actions, policies, and products. So I want to share with you all now my email address as well. Moving forward, if folks have questions or if you have requests for further training, technical assistance, we are very fortunate that SAMHSA funds these products and projects and allows us to go into communities, states, regions to do training, especially when it comes to impacting disparities that our Latino populations are experiencing. The disclaimer, again, like I mentioned, this is 100% funded through SAMHSA, always understanding that the citation of this source is appreciated. We ask that you don't reproduce these, we don't charge a fee if you do, but we just ask that you coordinate that effort with the National Hispanic and Latino Mental Health Technology and Transfer Center. At the time of this presentation, Miriam Delphine Rittman is serving as the Assistant Secretary for Mental Health and Substance Use Administration of SAMHSA. With all of that said, I have no conflicts of interest to disclose at this time, and that is always a good thing. As we know, Suicide Prevention Awareness Month, it really, unfortunately, is narrowed down to Suicide Prevention Week. However, we've tried to, and nationally trying to expand that to at least make sure that we're paying attention to this for at least 1 month out of the year. But we know it's such an issue that we need to pay more attention to it and draw more training to individuals that see these folks coming into their office, to their schools, to their community agencies, churches, etc., and presenting suicidal. We want to arm everybody that we can with those skills to be able to recognize that. We're also blessed because we're in the middle of Hispanic Heritage Month, which started last week. So I'm very happy and thankful that I'm able to bring these presentations to you as part of Hispanic Heritage Month as well, remembering and celebrating school mental health personnel, who is a critical and vital link between Latinx communities, families, and children. And then, of course, to all of our service workers, our Latino service workers out there, farm workers, folks that continue to work during the pandemic to put food on our tables so that we didn't have to go without. Today, again, as a reminder, this is Module 4, Assessment, Prevention, Intervention. Next week, we will have Module 5, When Suicide Happens in Schools. So you see all 5 of these modules. We're also trying to integrate more of the resources that I'll share with you today as well, so that as people leave this training, there is a growth of knowledge around resources, around just feeling more armed and comfortable with discussing suicide. It obviously is never a topic that is comfortable, and it never gets easy. It never gets easier. It seems to, for me, and I am thankful in many ways that in my work, direct practice work, that I've been in a position and in roles to help increase accessibility for individuals experiencing suicidal ideation, thoughts, etc. And one thing we have to try to do is become more aware of the services, of the resources, but also with our own comfort of talking and dealing with the subject. Like I mentioned, I've come to this field through the school, through social work, however, clinical social work, however, as I mentioned last week, I never thought that I would actually be working so deep within kind of the realms of this huge social determinant and disparity, I should say, in the United States and in our region. I am coming to you, I don't think I said that yet this morning, but I'm coming to you all from Albuquerque, New Mexico, so right in the Midwest. And we are seeing significant increases. If we weren't already seeing disparities within suicidality among Latinos, we're now seeing an even more of a dramatic increase given COVID and some of the outcomes that we're seeing from this pandemic. And then we're not over yet, right? It's not over yet. So we're still working through some of this. I definitely want to include in some of these modules some self-care strategies and being aware of that as a person who works in this field. I think all of you that have exposure to this will definitely need to be aware of giving yourself some grace and being aware of how you respond to situations when you are dealing with suicidal clients. It is not an easy topic to discuss. Sometimes our own cultural beliefs and values may come in conflict with our clients' views of suicide, and we have to try to work through that. So today we're looking at assessment, prevention, and intervention. Part of what we want to make sure of through the assessment, prevention, and intervention is that we at least identify and cover these 4 objectives. So one is we want to examine variables that may impact assessment and engagement. 2, address best practices to establish intent. And then 3, discuss intervention practices with Latinos. And the last, number 4, is to identify family-centered intervention for Latinos with suicidal behavior. Now, one thing that I want to mention is this module is a little has less slides than our previous module, not meaning that it still has quite a bit of content though, and that's why I think it's important that we just kind of spend some time and be able to introduce each one of these areas thoroughly and not rush through them by any means. So just know that we have some time built into this today because we wanted to really make sure that we are able to also not only share with you the resources that we've placed in the handout section here, but also I will bring those up and we'll kind of look at them and talk about them more directly so that folks are feeling more comfortable with the instruments as well. I think one thing that I've seen in my time in doing this work is, as a clinical social worker, I've been licensed for 21 years. It seems as though suicidality, or at least our assessment and awareness of those behaviors, are becoming more prevalent, and I'm thankful for that. However, it does mean that we have a huge responsibility and way that we have to respond and be accountable for the way that we respond as agencies, as licensed professionals, as individuals who are in positions of having a duty to inform or warn if somebody is putting themselves in danger of suicide or at risk of suicide. So it's important that as we jump into this, that your local laws, your local policies relative to your agency and or your community-based agency, whatever that looks like for your school. Make sure that you understand what those policies are and how you're meant to respond. Now, if there are no policies around addressing suicide in your schools or in your community-based organization, I think this may give you hopefully that encouragement to definitely take a look at those and start to examine what is your policy that says how you respond if a client in your agency or school, or again community agency, whatever the environment is that you respond in an appropriate way that minimizes risk. So with that said, let's look at this first slide. So, one of the things that we want to make sure of is that we take our time with engagement and assessment. Um, it's very easy to jump into just seeing the symptoms and putting that into kind of a symptomatology with ideological roots that you have maybe made some assumptions about. However, I think it's important that we consider that until we really know the client to a degree that we can create a therapeutic alliance with, we may just be getting surface level information, and that may lead to misdiagnosis. It may lead to um, um, treating the client inappropriately and not considering cultural values and customary practices within the Latino culture. I think I mentioned this briefly last week, but some of the things that we have to, I believe, really assume that you have coming into this training. And if you don't have this training of cultural elements, I would strongly encourage you to seek us out. Ask us if we can give this training to you. Go online. There's a number of YouTube trainings I think that I've done, and a number of other experts within our center have completed over the last year and 18 months or so. But that's again basic cultural elements for Latino populations. And it has elements that we talked about, or I kind of briefly touched on last week, like the importance of familismo, like the importance of respeto, really making sure that we're taking respect and familiarism, family as core cultural values as we build this relationship. And that leads us to bullet 1 here on this slide, right? Is explore client and family's views of service providers and the service providing agency. Like I mentioned to other groups, and I may have briefly mentioned it last week, but by the very nature of the work that we do, most clients, and this is lay community members, maybe that don't have any exposure to behavioral health, mental health, substance use disorders, any of those things, will assume that we are part of the government in some way, right? And we definitely have to do our due diligence to make sure that we separate that out as we get to engage and assess the family. But I think it's a reminder for us to also think about the fact that clients have a certain view of you as a provider attached to a community agency as they come to see you, or as they're referred to you, as they're court mandated to come to you, right? Whatever the referral source may be. And it's really up to us that if there has, or we get a sense that there's been previous unsuccessful interactions with other service providers, that may impact engagement, that we take time to address that. I think it's important that we do so in a manner that is exploratory in nature, that is non-assuming, that we don't place blame on the client for an unsuccessful interaction. The unsuccessful interaction may be at the very hands of the agency or the provider that maybe missed the opportunity to connect and engage in a thorough and culturally sensitive assessment. So I think we have to be cautious that we don't always, or we don't jump to blame the victim in certain instances where maybe systems have failed them. And systems have failed Latinos to engage them culturally into a system that typically is not created for them, right? Or is typically created in a medical model where it's very much client, doctor and patient and family, other aspects of support that are very much cultural values of the Latino population may get ignored or not addressed initially at that intake. The cultural formulation interview, and I'd rather, instead of us kind of go back and forth and me stop sharing screens, I'm going to go ahead and just save that. So just know that for engagement and assessment, the cultural formulation interview, in addition to other assessments or intakes that you may have to complete, during that initial engagement phase, are important documents to really look at. And I think we have to be considerate of the fact that some of these, like Columbia Scale for Suicide Severity, is a instrument that has been rated over time. However, we definitely have to think about how we can adapt some of these things, or maybe adapt some of the questions slightly if they don't exactly fit culturally with our client population. Cultural formulation interview, thankfully, that is one document I think that has had experts that are actually based in our center and have worked for the center over time, have helped create that document to a point where it is culturally sound, and it does really help if you're working in tandem with the cultural formulation interview, let's say, and then other intakes and assessments you may have to complete, including the Columbia Scale for Suicide Severity and Risk. What else do I want to say about this slide? I think the other piece to this, which is a balancing act for me, is although it takes time to get client engagement and to do assessments, when a suicide is the presenting behavior and risk that we're addressing, we have to try to speed this up just a little bit, right? And it also makes sure that we don't miss any steps, meaning that we don't assess risk and intent clearly to a point where we send someone home without a immediate warm handoff for a further psych eval, or maybe even for an inpatient evaluation, and we potentially allow this client to go home. Potentially we're putting that client and their family and that community at great risk for this individual carrying out the suicide maybe that they were reporting to you. So we always have to very much compile our risk assessment with intent, which we're gonna look at here in just a little bit as well. Okay, so remember, with this slide, we're gonna bring in our cultural formulation interview, and that's a document that I'll share with you guys in just a little bit here. So, establishing intent. Assessing intent is based on what the person describes or reports as past or present evidence. And this has to be, it can be whether it's implicit or explicit evidence, right, that the client is saying to you, and we'll look at that in more detail in just a little bit. That he or she wishes to die, has the means to kill him or herself, and knows the potential consequences of the action. So when we're looking at intent, many times we see kind of surface level intent, meaning that sometimes with folks, individual clients that have not taken their plan to the next step and gone through kind of a process like it explains here, but they kind of stay in this area here where it says they wishes, or he or she or that person wishes to die. Many times when we see the warning signs of suicide, we see individuals leaving notes, making subtle statements. I wish I were just gone. People probably would wish I was gone, and if I were gone, people would probably wouldn't even notice. Or I wish I were dead already. All this pain would just end. Statements of that nature, sometimes at the initial stage of someone searching for options in order to heal the pain, the trauma, the experiences that they're going through, may seek suicide as one of those remedies, right? However, at this level, we see that this individual probably is really searching for help and looking for a lifeline. And again, you're pairing that, so that I don't remiss this part, you're pairing that with the past and present evidence, right? Have they actually attempted suicide previous to this? Have you found, or parents found, or their significant person in their life ever found a suicide note, or notes or diaries that had suicidal wording or language in it, like I mentioned before? The next element that comes into play is, has the means, right? Does this person have the means? Meaning that if we look at the means of suicide, we see that females typically have a much more likelihood that they will or take their life by suicide through a means of hanging themselves, right? Um, and usually, and or through medications, prescription medications, and or other illegal drugs that may be in the system as well at that time. But the means to kill themselves is very important, and we have to understand that based on gender and identity as well, right? Typically, males have a more lethal way, or seek more lethal means to kill themselves, which is typically by firearm, and of course other drugs, legal and illegal as well. However, we definitely see the intent for males becoming much more serious as time passes. That's not to say that the lethality over time isn't equal, right? Meaning that women may take their lives at even higher rates than males, but it may take them longer to get there, meaning that they may have more attempts, and meaning that there may be more opportunities to intervene in between that time, if that makes sense. We definitely want to note here that as a clinician, or as any sort of service provider, you should not dismiss any indication of a suicidal planning process, no matter whether the plan is possibly lethal or not, and or whether you think that they have access to that. Now, it definitely comes down to in some cases, that kind of gray area, and we have to understand, our gut feeling on things. I would always strongly encourage you to err on the side of caution, right? If there's any indication of a suicidal planning process, I would always err on the side of caution, get family involved, maybe even, again, schedule them to do a psychological evaluation if that's not something your agency or you do, but also at that moment, do the suicide risk assessment, right? That we're going to share with you, Columbia risk assessment, and that definitely becomes an important element to what your next steps may be. Now, I think it's always important also to not rule out, when we talk about culture, right? Sometimes we think, especially in males, that not all the males that we're seeing, or the males that provide, or I should say, show up in our office presenting as though they may be suicidal, that maybe not all of them have access to firearms. Well, you have to be cautious, right? Sometimes we take only into account pistols or handguns. We have to understand that rifles also become a weapon of choice for many individuals, especially when we look at cultural values of hunters and gatherers, like many Latino communities, especially in our region, northern New Mexico, who do a lot of hunting, fishing, camping, those sort of things. Usually there are firearms and there's weapons involved, and many times that not only includes handguns, but may include, again, firearms, shotguns, rifles, that you may not always think that someone may use to take their own life. So you never want to put that past anybody in terms of the intent, and if there may be a planning process that you don't assess initially as lethal. We always want to err on the side of caution in those cases. Continuing our establishing intent, I think it's important to ask about intent. We can't be fearful, just like when we talk about suicide, but when we also talk about relapse with folks that are in the dealing with substance use disorder, misuse, etc. We can't be fearful or shy away from establishing intent, right? Many people think that if we ask, do you have a plan in place, that may lead somebody to take their own life by suicide, when in fact it's just the opposite. Many people may feel relief that somebody noticed, that someone reached out, that someone took the time to recognize and to draw their attention to maybe messages that this individual client may have tried to send many times before, and without any success. So don't be fearful. I think it's definitely something that we have to. It's kind of like I guess in this case, I would use the duck analogy a little bit. On the surface, we got to remain calm, and we got to kind of go with it, and we got to seem as though we're not responding. But underneath, just like within our own mind, right, those little feet are moving a million miles a minute, and we're starting to put into play a plan for how we're gonna excuse me, a plan in play for how we're going to address this, how we're going to get somebody or we're going to do a warm handoff to somebody. Are we going to connect them? Are we going to have a family intervention at that moment and bring everybody in to do a family safety plan around suicide prevention? What is our next step, right? And that takes us to our second bullet here. I think we have to just be cautious that sometimes a suicide plan may look very loose. I don't think that we should too often look for a specific plan that is step 1, step 2, step 3, step 4. Sometimes this may come in the form of a journal or journaling, where someone is brainstorming their thoughts and their feelings, and that may come out as a more loose or loosely established plan. However, it may be very, very specific, right? So we just have to be cautious and not get lost in any of the looseness of a plan and not take action, right? Safety is paramount, and I can't state that enough, right? We always have to err on the side of caution. If the plan is very specific, I think that it definitely means that this individual has probably thought in very close detail about every single aspect of that plan. And that also includes them thinking about who may show up to my funeral, who is not going to show up, and all of those things start to add fuel to the fire, so to speak, right, in the plan. And it may be more fuel to that individual actually carrying out that intent. So we want to ask for that. Now, I think it's always important that we're cautious in the sense that we don't want to re-traumatize or re-trigger somebody by having them walk step by step through their plan. But I think that we definitely have to get some validation and affirmation on some of the things in that plan if they are questionable to you. And I think that's kind of the if you will, the art and the science of what we do as clinicians, right? The art being that our gut instincts tells us something, that we something doesn't feel right, something we have to be cautious in this case. We have to ask questions. And then the science comes in when we do these Columbia scale inventory, right? When we do the cultural formulation interview, and we get very, very specific information that's going to hopefully help us to create a picture of what's causing this intent, or maybe there's past behavior, trauma echoes, and historical trauma maybe that be maybe playing into what we're seeing in front of us at that time. We definitely have to take the time to address and adjust our treatment plan if we're seeing suicidal ideation take shape and it come up obviously in a session. If we're looking at a clinical setting, this makes it very important for us to bring out the treatment plan and revise that treatment plan. Obviously, if the client is presenting as suicidal, there may be ways or things that we need to do to adjust that treatment plan, whether it's making more culturally appropriate adjustments, maybe it's taking more time to talk about the depression, the suicide, the trauma that this individual is experiencing. But it definitely is meant to create or lend itself to create or the creation of a safety plan, which if you choose to use the Columbia scale, for suicide risk and assessment, it starts to give you that. And that's why I usually look at that, especially when we're talking about adults. Now, for adolescents, you may need to make some adjustments. There are some other good screeners out there that you can look into, and that maybe if there's an interest in that, or folks even want to share those, if you all have that in hand, please share those with our group. But also, if folks have that interest for the adolescent instruments, I can see what I can do about bringing those into our next session, our final section next Monday. So what's in a safety plan? Well, you definitely have to get an inventory of what is, who is there as a resource. So you start to identify your resources, right? Who is a resource? Mom, dad, grandparents, friends of the individual, family, other family, extended family, maybe a clergyman or a pastor from the community. Maybe it's a healer, a curandera in the community. Who else is there to provide support for really making sure that we are addressing these areas that are presenting themselves? So that is its top line for me, is who's listing our resources, right? From there, we then have to create kind of the procedure, if you will, of a policy, meaning that if the individual presents to mom and says, Mom, I'm feeling very sad, I'm feeling suicidal, at that point, mom is committing to do A, B, C, and D, right? A is to sit with the individual and not to leave them until these feelings pass or they address them. Maybe the second thing is to call a crisis helpline if that's accessible, or the agency that this individual may be seen at may have an on-call 24/7 crisis line, which they should if they're serving clients that are presenting as suicidal. However, this may be a school system, and that may not necessarily be the case, right? So if you come into play and you see that this is happening, I think it's important for us to really start to make a plan that's really measurable. You have the resources listed, and then you have the steps that you're going to take if so-and-so presents to mom, to sister, to grandparent, suicidal, feeling sad, etc. There may be also keywords that the individual uses that may indicate to them that they are feeling a certain way. Maybe it's just sadness and depression, but maybe as though that they are feeling as though they're not wanted around, or as their life may not matter. So those are definitely things to think about. And I have a question here, so I'm gonna go to our question real quick, as we're right at the midpoint, I think. So I think I'm at a good time. So regarding ideation and planning, can you say anything about involuntary treatment and police involvement? Are there any alternatives that you can suggest safely? Any alternatives that you know that are being worked on? Well, I think that's always a question that comes into play, right? I would definitely reach out to NAMI if I were in your position. The National Alliance for Mental Illness, as they always have really good ways of helping you understand kind of the rights of clients, and on the other hand, we also have to know within our school, within our licensing body, what is our duty to report and inform, right? That if you're a licensed professional, definitely take some front seat consideration as you're working towards developing a plan. Now, I think that I would always err on the side of caution. However, I think what you're maybe drawing from in the question, or what I'm drawing from your question, is that we don't want to impact or damage the relationship we have with our clients either. However, like I've said before, safety is paramount, and I would rather chance the impact to that client relationship a little bit if they feel like maybe you broke their trust, or if you shared something with someone that they asked you not to. However, we always have to lead with, especially with clients that may be presenting suicidal, that we have a duty to inform and to warn, right? So if we're always reiterating that throughout our interactions with families and clients, that shouldn't be a shock to them, right? That shouldn't be something new that they're hearing for the first time. So I'm hopeful that through your relationship building and using of cultural elements to build that relationship, that potentially you won't do harm, and that you will do it safely, because they know and understand that you care for them, and you're bringing that to somebody's attention because you are afraid that this individual may take their own life. So again, we always want to err on the side of caution. We always want to make sure that we're following law and our policies and procedures, and that we're, again, not leaving someone to kind of fend for themselves in a position where they may be explicitly seeking help and assistance at that time that they come to you. Thank you for the question. Great question. I don't know that there's anything being worked on. I would say that there is a lot being worked on. AFSP, American Foundation for Suicide Prevention, I'm actually helping them adapt their manual to also include or consider Latino populations. But I think their effort is trying to arm all community members, volunteers, people that you would not think would be dealing with suicide, as someone that is trained and actually ready to help with that in the event that they are. So I think getting more community members, lay people that aren't necessarily behavioral health or addiction treatment professionals, but just lay people in the community, is definitely a great start, and I hope that continues as we move forward. Some additional reminders that we want you to think about is really thinking about what is the potential possibility that the individual will act on that plan. Again, we want to err on the side of caution. We don't want to kind of throw caution to the wind and say, "Oh, I think that this person will be okay." That's always a recipe for disaster. And like I said last week, you don't want to be that individual. You don't want to have a team member or anybody on your team have to lose a client to suicide when it was preventable, right? So we always want to be cautious. We always want to ask, what is the likelihood that this person will be found and rescued if the plan is implemented? Right nowadays, there's going for people are actually going into this situation where they're using apps to track clients now, and those apps have kind of a GPS component. There's one here in New Mexico that's called Smart Recovery, and it's although it's a suicide, although it's an addiction and substance use disorder accountability app, it does have a GPS tracking component to it, to where if a client is in crisis and an emergency, you may be able to track them down through their cell phone location. In New Mexico and rural communities, rural counties, this is extremely important, because we know even in New Mexico, I do some contract work with McKinley County out in Gallup, New Mexico, and in some places within the Pueblo and even on the reservation, the Navajo Nation, we see pockets where GPS doesn't work or Wi-Fi doesn't work. So this becomes a very very much a life-saving kind of element that we always need to think about. What is the relative lethality of the plan? Can it surely lead to death? So we don't want to be forensic analysis experts. We don't want to have to make those decisions, but you always want to think of those things, right? Are they in a rural location compared to a metro area? Are the chances that they would get to emergency care faster an issue? So we're always thinking about all these other environmental factors that we need to think about as we're going into again assessing intent, and I want to make sure that we think about that a little bit. There's also some, let me see here. So there's a question here from Brenda. Thank you, Brenda Hartman. Shouldn't we educate families on what mental health is before we are able to talk about suicide with them? Well, that would be great, but what if that doesn't happen? What if the suicide comes to fruition before we're actually able to educate family members? So it can't be a cart before the horse kind of process, right? It has to be one that maybe there is a history, as you're saying here. Maybe there's a history of familial depression, a familial history of suicidality. That all is great if you have the time to really get to that and uncover that. However, if a suicide is presenting in your office day one of the referral to you, you may not have that time to really get that history. Echo mapping and also genograms are very, very helpful tools if you're coming from the world of social work or counseling, and I would definitely utilize that because that will sometimes tell you if there is a history of family suicide or history of trauma, maybe a history of um, historical trauma, right, in indigenous communities as well. And then the comment was, growing up when I was depressed, my parents would tell me you need to clean, or if it wasn't eating, it was because I was in love. Absolutely. Sometimes there's definitely a disconnect between what family members think is going on with someone because they're experiencing depression, sadness, maybe anxiety, and they don't always attribute it to suicide or depression, right? So I'm all for mental health first aid, teaching families and parents, about mental health awareness. However, if we're having to do that as a parallel process, I think teaching families about suicide is something that sometimes comes even before our ability to train them on behavioral health and mental health stuff. But prevention includes getting out mass training on suicide prevention, mental health first aid, and really getting kind of that framework laid. So excellent point. Thank you there for sharing that, Brenda. I appreciate that comment as well. Next, we want to look at establishing intent. Again, and I think I went back on that, but just safety plan is key, and we don't want to make any mistakes in that part of it. Now we kind of get into the interventions with Latinos, and the website www.sprc, which is Suicide Prevention Resources Center.org, is a great website that has a number of different resources available to you. I think that you also want to make sure to really look at behavioral health organizations that you're a part of and see what are pathways that we can create around suicide risk in order to ensure patients receive follow-up, referral sources are happening in a timely manner, and particularly during high-risk periods. Another thing that I would say is going on in our community is we're starting to establish community response teams, which are really law enforcement officers paired up with a behavioral health licensed clinician, and they respond to a suicide call or someone who's in crisis, as opposed to sending the paramedics and law enforcement and all horns and sirens blazing. They go in with a kind of a less of a presence in order to help connect that individual to a professional to assess for suicide if that's the case. And this is happening more and more in our region, and I'm hopeful that would be something that's happening in other areas in our United States as well. Some additional reminders for interventions. The 5 safety steps that we want you to just kind of think about is identify risk factors, identify the protective factors, right? Definitely conduct a suicide inquiry, asking about thoughts, planned behavior, and intent. Determine risk level and intervention, and we're going to give you a couple of other tools today to also help with that. I think one thing that I always felt when I first kind of got introduced and exposed to some of this work was that I was not prepared to deal with suicide, or someone who was actively suicidal or thinking or planning or presenting in my office with evidence of self-harm because they were having pacts with other adolescents in their school around suicide and suicidal behavior. And that's something that I'll share for next week once we get into, really looking at when this happens within school settings. We always want to determine risk level and intervention, what intervention is most appropriate. Is the intervention risk assessment and getting this connection, or doing a warm handoff and connecting this individual to a psychological evaluation, or more of an inpatient stay where they get to a place of balance and homeostasis, and they're assessed and triaged effectively. The last piece is obviously the cornerstone of our work: document the assessment of risk, rationale, intervention, and follow-up. You can find this at the SAMHSA store, and SAMHSA has some pretty good references, or resources I should say, and references for suicide prevention work in your community. One website we're going to look at here in just a little bit is one of those as well. But I think it's always important that we understand how much more of a spotlight gets put on cases that involve suicide, right? So we have to understand that your liability, not only for your agency, but for your school and your licensed clinician, goes up extremely high. So we want to do our best to make sure that we're as thorough as possible. We're documenting. We're following up. We're continuing to assess for risk ongoing. Assessment of risk within a suicide case is not just a one-shot deal, right? It's an ongoing assessment of risk. And I think that's important that we state that, right? It's not just a one shot in the arm and we're assessing risk. Oh, today you're good. Next week you may be at a 10 out of 9. I mean, a 10 out of 10 for high risk acuity, right? So we have to understand that may change over time. So ongoing assessment of risk is key when we're looking at suicide prevention and preventing someone from going to that next step of taking action in their suicide plan. Let me look at time. Okay, we're at about 10 minutes till, so I want to make sure we get into the documents that I brought for you guys today. And according to Zaya, some family-centered interventions that maximize the effects of intervention for adult and Latino adolescents definitely needs to be considered, right? And the therapist's role in assessing those interventions very much has to be to clarify expectations, look at the conflicts, translate family members' cultural behavior and experiences, encourage compromise and negotiation within the family dynamics of communication, especially when there's generational and acculturational differences, right? I think we talked about this last week. I know Zayas did in his first week with you all covering modules 1 and 2, but the acculturation gap that happens in families a lot of times may cause conflict or communication issues that we can resolve and we can help families, address in a helpful manner in order to help resolve the conflicts and, of course, additional stress that may be going on with what they're experiencing, right? So again, the role, just in summary, we want to clarify expectations, we want to justify and clarify conflicts, rationalize and translate family members' cultural behaviors into some norm and understanding, encourage compromise and negotiation, and especially we want to look at these things when we're dealing with generational and acculturational differences between the family, parent and child, grandparents raising grandchildren, and even when we see young mothers raising kiddos themselves, right? Single parent families are significant in the Latino population, something that we definitely want to make sure we address. I'm sorry, let me go back one. Just want to make sure that I covered this. Okay, yeah, okay. Additional reminders: assess patterns in communication, disciplining, and emotion regulation. And we also want to look at specific behaviors within the family around how parents are joining, how you're joining also. And then what is that insider view, right? You as an insider within that family, you start to become culturally sensitive and aware to the family dynamics. They're responding to you, and now you're definitely seen as an insider and as part of that that dynamic that's now creating that therapeutic alliance and continuing to build our protective factors moving forward. Restructuring may need to happen, right? As a means of promoting adaptive interactions with families. Sometimes we see young families just having role clarification needs and role defining definition. And I think when we help them define their roles within the family, that helps significantly, especially when we're seeing family members who have immigrated at different points and at different times, different levels of acculturation. Sometimes it's about bringing all family together to really understand whose role is what, and how can we effectively communicate our needs as a family now that maybe was once separated and is now, rejoined together in the United States or in your community, etc. Some additional models that we want you to think about and consider before I get to our last couple of slides, and then I exit from this screen and share with you a few of the handouts I wanted to share with you today. But one is multi-dimensional family therapy, MDFT. This is Lytle, Rodakoff, Ungaro, and Henderson. I think the SIFTA is a really good tool also. It's a culturally informed and flexible family-based treatment for adolescents. And they recently developed a treatment that is really culturally informed. And Santisteban is the primary author, and Mena, and Santisteban is actually a content expert with the center, or has been in previous years as well. And SIFTA is now actually listed as one of the evidence-based models on the Registry of Evidence-Based Models, as far as I'm aware. That's as of the last time I checked. Familias Unidas is a way of really building in kind of this storytelling element. So families usually that come from Latinx populations really have this storytelling or oral history as a cultural component of their experience. And sometimes that oral history and storytelling can also be a transmission or transferring of historical trauma. Right, of trauma from immigration experiences. So we definitely want to have that as a recommendation that you think about. And I apologize, I didn't include, I will update this and make sure I include the year of when that was published. It probably is in the references, but just so that we're all on the same page with that. I definitely want to go into seeing, I think there's maybe one more question, maybe a couple more questions. Let me get to that, and then I will open it up to any other questions that maybe Edmari sees on her side and I'm not seeing. But this question states, my agency has a Z7 grant, so we do the Colombia with all clients. What I have learned is that many of my Latino clients, in particular first-generation clients, will answer no to the questions. Yet, when I break the questions down, they do rate as moderate. Also, in my experience, some do not fall in the category of thought plan. Some go straight to suicidal behavior. Are there better cultural assessments instead of? I would say that it would be a really good idea. Thank you. That's a great comment, Rigoberto Contreras. Thank you for that. I think it's important, given that his experience with this, and like I was mentioning, what I would probably do is join the two together in some way, or figure out a way that you can blend some of the questions from the cultural formulation interview into your Columbia scale. And like he's mentioning here, right? That's just a screener that they're giving to all clients that come through their program. You may decide to do that as a mechanism for screening the number of clients who are suicidal. However, it's pretty consistent in what he's referring to, in the sense that Latinos sometimes will typically look at suicidal behaviors and they'll jump to that before there's this kind of long drawn out process, whether that's immediate response or immediate reaction, impulsivity. Again, we have to think about some of those things, but I think it's important that you kind of slow it down and take some time to as Rigoberto is mentioning here, really break down those questions to where they're more culturally appropriate. So let's go ahead and look at that. And Edmari, I'll check with you real quickly before I transition, and then I have one more question here. Let me take this one, and then I'll go to you, Edmari. And then, of course, as we're transitioning to these other documents, please feel free to put some more questions up in here and we'll do our best to answer those. My email address, I forgot to give this to you guys earlier when I said this, is drjrocky@gmail.com. And if I have a moment here in a minute, I'll throw it up in our chat section there. But it's Dr. J Rocky, all one word, at gmail.com. drjrocky@gmail.com. All right.
Sorry,
Does the
I will put it on the chat. Don't worry.
Awesome, thank you. And I have a question from Kiara Mead. Does the organization offer any Spanish classes? I work at the elementary school with a large population of Latino students and we communicate better with our families. We don't offer Spanish classes. We do offer trainings in Spanish that are adapted to Spanish. And of course, this probably would be one that we could easily convert to Spanish content. But I would definitely encourage you to reach out to me. I'm going to go to another slide here in just a minute that includes some of our information. So please write down that information, send us an email, reach out, and follow up on your question there, Kiara. I would really love to talk more with you, or someone from our center can follow up with you and make sure we get your needs met or help support you in that. You can also email me and I will connect you with our center if that is needed. So I'm going to go ahead and go to our next slide. Please go ahead and again throw your questions up there and I will get to them before we end for today. Our next course will be our final module on October 4th, same time as this week, 1 o'clock Eastern Standard Time. Thank you to our director, Dr. Ivis Charion, to Angel Casillas, our project manager, our website, and of course you can follow us at our Twitter feed and Facebook. Our website is www.mhttcnetwork.org/Hispanic Latino / and our email address, HispanicLatino@mhttcnetwork.org. So with that, I'm going to stop sharing my screen real quickly and see if I can bring up for us these documents. So real quickly, I want to share with you guys and let me see here. So you all should have right now on your screen, showing the main screen here, Columbia Suicide Severity Rating Scale, Risk Assessment, Lifeline Crisis Center version. Now keep in mind that this also has some websites for you here that you can get some training. I would highly encourage that if you get this training, of course, that you get your staff trained, whoever's going to be utilizing this. But some of the initial questions, really get down to the basic suicide and self-injury behavior in the past week. Actual suicide attempt, interrupted attempt, aborted attempt, self-injury without suicidal intent. So with somebody cutting their arm, we've seen people who have burnt themselves. Some adolescents will use a eraser from a pencil to erase and burn their skin to a point where it leaves scarring. So those are some of the things that I've seen, at least in my experience. Some, again, when we're looking at suicidal ideation, most severe in the past week, wishes of being dead, suicidal thoughts, thoughts without method, but without specific plan or intent. And then it gets down to a specific plan, right, with intent. Activating events, was there recent loss? Was there pending incarceration or homelessness, current or pending isolation or feeling alone? And this is where, again, I would definitely encourage you to expand your questions. Sometimes when we're doing these sort of assessment or risk assessments, we stick solely to the question and we don't deviate from that. I think with Latino populations, in some ways, you're going to have some follow-up questions that's going to help them better understand the question and maybe what you're asking of them. So let me get back to this one real quick. Here, client status, again, helplessness, hopelessness, feeling trapped, etc. Protective factors, what's going on that's going to help keep this person alive? Is there someone that they're engaged with? supportive social network, family, responsibility to family or others, belief that suicide is immoral, high spirituality. So these are some questions that you may ask Latinos around their religious and spiritual beliefs, right? And that's also where the cultural formulation interview comes into play. The second or third and fourth sheet here, if you will, or in this one it's fourth and fifth, this is where it gets down to the bulk of the information, right? And in these cases, you're actually doing yes or no answers with a 1 month follow-up question. So have you wished to be dead within the last week or within the last month, right? Non-specific active suicidal thoughts. So I won't go through every single one of these questions, but as you can tell, and I hope that if you haven't been exposed to this, that you see this as a tool or a resource to at least reference. This is usually a really good tool that if you are doing your initial screening for clients and they report suicidality, if you don't have an intake or a screener to immediately kick in the moment someone says, yes, I've had suicidal injury, I've had suicidal past, I've attempted suicide, I've had a plan. If you have yes answers to any of those should create a red flag for you or your agency to have a licensed clinician do a more thorough suicide risk assessment, right? If not, we may miss something and someone may end up taking their life by suicide. And or we may be putting someone at risk for taking their own life, if not at that moment down the road, if we're not taking their reporting of these situations as serious, right? And then at the end here, it starts to go into where you actually assess for your, as the clinician, what do you think the lethality is? Well, are they going to act on their behavior? Do they have the means? If they were interrupted? So really, it's important that we look at that. And then here on the left, I forgot to mention this, the intensity of the ideation. That's extremely important, obviously, as we're moving forward, right? And assessing this for clients or having them assess this in more detail. The other form that I want to share with you, give me 1 second here, is the cultural formulation interview. And the cultural formulation interview, again, you can find this. There's a website here where you find more information. Even if you do a YouTube search, they actually have cultural formulation interviews that are live conducted with clients. I want to say that the clients, the ones that I've seen, are actually live clients, not actors portraying clients. But this cultural formulation interview really gives you, and it's a guide, right? So there's a guide here that helps you to really understand the questioning and what's the intent of it, and then gives you the actual exact way to ask the question. So you're not having to create necessarily other ways of asking it. It gives you very specific ways to ask a question. Now, you're very much encouraged to adapt it as you see fit, specific to your Latino population. Working with Latinos in the United States who are, native to this culture and to this community and to the United States may be a much different interview, and some of the questions may be different from that of a family or individual who is a first-generation immigrant and who may have immigrated to this country within the last, 6 months to 1 year, right? Much different in terms of some of the questioning that we would ask. So cultural definition of the problem, cultural perceptions, cause, context, and support, roles of stressors and support, roles of cultural identity, and then cultural factors affecting self-coping and past helping skills. And then the last one here is cultural factors affecting current helping seeking, right? So it really just gives you ways to ask the questions in a more culturally sensitive way that includes questions about acculturation and immigration and other things that you may want to know from that client as well. And then the last form I want to share with you guys here, or not form, it's actually just a resource, is the Zero Suicide. And if you go to the Zero Suicide home here, this is a study that has recently been done. And I think that you may have some interest in this as far as some of the resources. There's also here toolkit. There's some articles and other things, and then under the evidence, there's research articles and evidence as well that will give you some knowledge. But zero suicide is one actually that New Mexico is adopting, and this is, I believe, I don't know that it's 100% funded by SAMHSA, but I do believe that SAMHSA has some funding that has been committed to this that help to put this into play here. So I would encourage you to really look at this. There's some other and I'm going to go ahead and stop sharing here, but you can definitely see how research bountiful this is, and I would encourage you to just seek it out more. I'm going to go ahead and stop sharing my screen here, and I just want to make mention before we end our time together again. Thank you again for those of you that are with us from series to series, and for the last 4 modules. Those of you that are with us just for today, thank you for joining. We hope that you felt there was information that is worthwhile to you, and that you join us next time. Next week is going to be a module that is specific to what happens when suicide happens in schools, and we want to make sure that we give you guys some tools and resources in order to be able to respond if that hopefully it never does, but if it ever happens in your community, you have some tools and resources and ways to be able to support those who are responding to those sort of crises. I'm going to go ahead and check real quickly before we let go, and make sure that I answer any questions in the chat real quick. So Ermari, if you have any on your side, I'll go to you real quick, and then I'll finish up with any I have here on my side that may be available.
No, I don't have anything on the chat right now, but remember, if you can just type it and we can read it, or let me see, I think we have one in the questions. I don't know if you can see it. Yes.
Yeah, I saw
Where?
that one. Is the
Yeah.
scale available in Spanish?
Yes.
Yeah, that's I think the last question I have there. You know what? I apologize. I didn't do that search for it in Spanish. I want to say I have seen it in Spanish, at least the Columbia scale. Um, Now, as far as the cultural formulation interview, I would also say that we have that somewhere in Spanish, and we could probably get that to you at some point. I just need to do a little bit more research about it. So if you wouldn't mind, let me see who's asking. Amanda Cantu, if you don't mind following up with me and sending me an email, I'll work with you to get that. And then if I'm able to find that for next week, those of you that join us next week on our session, I will definitely put those on our handout section, so you have that as a resource as well. But I don't see any more questions on our side. I just want to leave you guys with this, and then we'll close it out if there's nothing else. But I think we have to realize how much trauma plays into suicide. And next week, I want to bring in a couple other resources that I'll share with you, especially around adverse childhood experiences, which increases, if someone comes with 3 or more adverse childhood experiences, the likelihood of them taking their life by suicide increases by 12 times compared to the national average. So we have to understand that trauma impacts suicide significantly. And with that said, we're also now seeing a significant uptick in trend in Latina suicides. So we need to really do our due diligence to pay attention to that, to really make sure that we're giving our Latina population our attention, and really paying attention to the signs that they're sending us around suicide. So if there's nothing else on your side, Edmadi, I would definitely ask you to close us out for today. Again, thank you all for joining us. I appreciate your time. Stay safe out there, and take care of yourselves.
Thank you so much, Rocky. It was amazing, very valuable information. See you next time, everybody. Thank you.
See you all. Bye-bye.